Hello, my name's Neil KHILNANI. I'm an interventional radiologist at Weill Cornell Medical College and New York Presbyterian Hospital in New York. I'm also the immediate past president of the American Vein and Lymphatic Society, and I'm honored here to speak to you about an entity that has been popularly described as pelvic congestion syndrome. I'd like to begin by changing, or at least encouraging, a change in the nomenclature from pelvic congestion syndrome to pelvic venous disorders. The rationale for that change is that pelvic venous disorders is actually more of an inclusive term, including all the pathophysiologies that could lead to pelvic venous hypertension. On the image on the right, you can see that can be ovarian reflux, internal iliac vein reflux, but left renal vein compression with reflux caused in the left ovarian vein can also lead to pelvic venous hypertension, and so can compression of either common iliac vein. And so to unify the various physiologies that can manifest with pelvic venous hypertension, we are as a group proposing the use of the term pelvic venous disorders. This would then include all of the entities that are previously identified as syndromes, such as the pelvic congestion syndrome, Nutcracker syndrome, and May-Thurner, and bring them into a unified hierarchy, and also eliminate any of the negative connotations associated with these terms, particularly pelvic congestion, which many gynecologists are very cynical about. These physiologies are obviously interrelated, and they should be described by a common descriptor. Just to review the physiology of pelvic venous hypertension, there's two forms of reflux. You can have reflux in either gonadal vein, or you can have reflux in either internal iliac vein. And there are two forms of obstruction. You can have obstruction of the left renal vein, which can lead to left ovarian vein reflux and ultimately pelvic venous hypertension, or in the absence of left ovarian vein reflux can lead to hypertension of the venous system of the left kidney, or you can have obstruction, whether it's thrombotic or non-thrombotic, of the iliac veins, and in the situation of the left common iliac vein compression that can lead to pelvic venous hypertension as described on the diagram, but either vein can do, either the left or the right vein compression can lead to the same physiology. There are four clinical presentations of pelvic venous disorders. The classic presentation that fell under the umbrella of pelvic, pelvic congestion syndrome is chronic pelvic pain in a woman. This is the definition of chronic pelvic pain in a woman. It's more common in women, but it can occur in men as well. The second presentation is pelvic origin varicose veins. They could be in the vulva or in the lower extremity. Again, these are more common in women. So here's an example of a posterior aspect of the left leg with pelvic origin varicose veins. The pelvic venous hypertension is escaping through the pelvic floor through one of four escape points, and filling, in this case, via the external pudendal veins, varicose veins on the posterior aspect of the thigh, which then would end up filling varicose veins on the lateral aspect of the calf. The image on the right with the letters I, O, V, and G are showing the P and G are showing the various escape points from the pelvis to the leg, I being inguinal, sometimes also called reflux through the recanalized umbilical vein. Then there's the obturator, the pudendal, and the gluteal, which includes veins that will follow the sciatic nerve. And here's an arrow showing the escape point in the patient that we're looking at. The third presentation is leg pain and or swelling with or without varicose veins in the leg. And this would be the kind of physiology you would see secondary to an iliac vein compression. And the diagram on the left shows the various pinch points where arteries can compress veins in the pelvis, and an example of a patient with unilateral left leg swelling. And the fourth presentation is the result of left renal vein compression. That occurs where the left renal vein drapes over the aorta. It may not be actual compression by the superior mesenteric artery as typically described in the previously known entity as nutcracker syndrome, but rather a kidney tugging on the left renal vein, causing the renal vein to tether over the anterior aspect of the aorta. And here's a diagram on the left of that kind of anatomy. The other presentation is left hematuria. So if you have uncompensated obstruction of the left renal vein without the ability to drain into an incompetent left ovarian or testicular vein, the patient can develop left flank pain and or left hematuria. And these are diagrams demonstrating that. So what do pelvic venous disorder guidelines have to offer us in terms of guidance into how to take care of these patients? Well, the gynecology literature has almost nothing. In fact, what it does have are comments that are very cynical about the actual entity of pelvic venous disorders leading to any kind of clinical symptomatology in patients. Here's a review, or rather a guideline from the Royal College of Obstetrics and Gynecology that's currently the most active, and the only comment they make about pelvic venous disorders is that they express doubt about whether it actually relates to symptomatology and whether treatment would help it other than potentially hormonal treatment. The only other obstetrical guideline in the world that has any mention of pelvic venous disorders is a recent publication in Canada from the Society of Obstetrics and Gynecology there. And again, they express cynicism about the value of treatment, as in the diagram on the right, which shows the underlined line, which questions the quality of the evidence supporting treatment of pelvic venous disorders. How about in our own venous community? What do our guidelines say? Well, they're pretty sparse in terms of comments about this entity as well. The only comment I could find was in the American Venous Forum Handbook of Venous and Lymphatic Disorders, and they give a 2B recommendation for embolization of reflux for chronic pelvic pain in women. Aside from that, there's nothing at all related to pelvic venous disorders and obstruction, whether it's the renal or the iliac veins. Pelvic origin lower extremity varicose veins, no guidance again, and no guidance with vulvar varicose veins. The diagnosis of pelvic venous disorders can be made on a clinical basis, and that clinical interpretation proven by imaging. The gold standard at this point is catheter venography, which on the left is showing a left, or on the image on your right, is showing a left renal vein venogram and demonstrating reflux down the left ovarian vein from the renal vein down into large pelvic varicosities. And so this is considered the gold standard imaging for this disorder, specifically reflux disorder in this particular image. But there are other, and here's another image of a different patient with balloon occlusion venography. But there are other ways to image this disorder as well. As a screening test, transabdominal ultrasound can be a wonderful tool. It's obviously used by gynecologists who see most women with chronic pelvic pain, and dilated periuterine varicosities can be identified on these screening exams, and this could be a trigger for a referral to a vascular specialist from a gynecologist. Here's a transvaginal ultrasound demonstrating pelvic varicosities. Again, this is a great screening tool. Gynecologists often perform these exams when evaluating women with chronic pelvic pain. And again, these types of ultrasounds can be used to make recommendations for referrals to vascular specialists. Once the patient's referred to a vascular specialist, a comprehensive vascular exam is necessary to both confirm the presence of pelvic venous disorder and pelvic varicosities, and then to diagnose the actual physiology. And in this particular case, a standardized approach to transabdominal ultrasound has been proposed in this particular document, and these are the surface landmarks that allow one to actually examine the pelvic venous system to look for reflux and obstruction. Most of the women who have pelvic venous disorders are quite thin, as demonstrated in other literature, and so these ultrasounds can generally be performed with a high degree of success. CT scans can demonstrate periuterine varicosities and enlarged ovarian veins, and if they're done rapidly after an arterial bolus, may even demonstrate the retrograde flow in the left ovarian vein. However, this particular test involves radiation, and I'm less likely to order this particular test for that reason in younger women whom we are generally examining for this particular problem. However, as in this particular case, this woman was seen in the emergency room with left lower quadrant pain that was relatively acute, which sometimes occurs in the context of chronic pelvic pain of a venous etiology, and the only thing found were the refluxing ovarian veins and the varicose veins in the pelvis. MRI works very well. The MRI images on the left demonstrate an enlarged left ovarian vein and periuterine varicosities. A time-resolved MRI can also demonstrate the varicosities. Unfortunately, this video isn't working, but these can create nice angiographic type images that are very demonstrative of the problem. I have another example later in this talk. In that same patient that we're looking at here, here's the left renal venogram demonstrating reflux, the balloon occlusion demonstrating left venogram, left ovarian venogram demonstrating multiple ovarian veins in the lower portion of the abdomen and true pelvis, and then the periuterine varicosities. Here's another patient with MR demonstration of periuterine varicosities, but in this case, these were thought to be related to compression of the left common iliac vein by the right common iliac artery. How well does imaging do as a tool to identify what was previously described as pelvic congestion syndrome? There was a systematic review from last year in the gynecologic literature, which concluded that the imaging data is of poor quality. There were 9 studies that were adequate for analysis, and which included contrast venography, catheter venography for comparison with ultrasound and MRI. The best criteria for diagnosing pelvic venous reflux in the interpretation of these authors was obviously retrograde ovarian vein flow, which can be demonstrated on both MR and ultrasound, and pelvic varicosities that were bigger than 5 millimeters in diameter, but also that were connected both on the left side and the right side by transpelvic or transuterine varicosities. So retrograde flow in the ovarian veins and 5 millimeter diameter varicosities connecting from the left and the right periuterine venous plexus. In terms of treatment, this is a very brief introduction, but I'm going to just try to share with you some logic rather than getting into details. Again, 2 primary presentations that we're going to think about here for pelvic venous disorders, because these are the most common, chronic pelvic pain and lower extremity pelvic origin varicosities. So in the case of chronic pelvic pain, the recommendation is to treat the abdominal pelvic venous pathophysiology directly. So this is generally accomplished best in a multidisciplinary fashion with a gynecologic partner, particularly a gynecologic partner who might be a pelvic pain specialist who can help in interpreting other possible etiologies for chronic pelvic pain. The team usually also includes a pain or physical medicine type person who has an interest in pelvic pain, a urologist, a gastroenterologist, and obviously we believe it should also include a vascular interventionalist, which many of these teams do not. Evaluation should include a history and physical exam, but the physical exam specifically by a gynecologist, supplemented by some sort of ultrasound exam and laparoscopy if considered appropriate by the gynecologist. Often these patients have more than one cause for pain, and although it may seem that they have just endometriosis or just pelvic venous disorder, sometimes they can have both, and it may require treatment of both conditions in order to make the patient better in some kind of stepwise fashion. And here's a laparoscopic image of dilated periuterine varicosities. In terms of treatment of reflux disease and/or, well, let's just focus on reflux disease. The recommendation that I'll make to you now is that you should consider treating the periuterine varicose vein plexus aggressively, much like in lower extremity venous disease when it's related to saphenous vein reflux. You can get some symptomatic improvement by eliminating the saphenous vein and not treating the tributary varicosities. You get more complete symptomatic improvement and physiologic improvement when you eliminate both the refluxing source and the varicosities. And this could be considered in the same fashion that Asval is considered when looking at the lower extremity varicose veins, in that perhaps the pelvic varicosities themselves are actually the more important thing to treat, and the ovarian vein or testicular vein less important. Now, of course, this is a bit of a stretch at this point to make that kind of statement, but I do want to sort of challenge your thinking on this and to encourage you to think hard about potentially focusing a lot of your attention on the varicosities themselves and the symptoms that they can be causing. Here are some pictures of those varicosities, and they can be quite extensive, and it seems silly not to think that they would be related to some of the symptoms. Likely they are the source of pain, and treatment of just the ovarian vein trunks may be responsible for some recurrent symptoms and incomplete responses in patients, which are seen in many of the trials. The approach to treat those varicosities at this point involves some sort of sclerotherapy using either liquid sclerotherapy, liquid mixed with contrast, so that you can determine how much volume to give, which is my preferred approach, or foam sclerosants, which you can use very effectively as well. Here's an angiogram, venogram of the right ovarian vein after left ovarian vein embolization, and you can see the remaining varicosities on the right leg. On the left leg, on the right periuterine plexus on the left side, the left ovarian vein was coiled after sclerosants were injected into the periuterine venous plexus. And here is a picture of a balloon occlusion technique to inject the contrast mixed with sclerosant to titrate how much sclerosant you need to inject. Following ovarian vein injections, it's important to check to see if any internal iliac vein varicosities are identified, and that's best accomplished using balloon occlusion venography. What you're seeing here are right and left internal iliac vein balloon occlusion venography in a patient who just had ovarian vein and peripelvic uterine venous plexus embolization and sclerosis. And what you're seeing are actually normal presacral veins, because all the periuterine varicosities had been sclerosed from the ovarian vein position. This is a very common observation and may be the reason we don't see the internal iliac vein-related varicosities is that they probably were already sclerosed from the ovarian position. And so obviously technique determines many of the findings and outcomes in the venography during the procedure and in the patient after treatment. And this is an example of what we would consider a complete embolization of the periuterine venous plexus. However, if you saw varicosities at that interval or at that time, when you did the internal iliac venography, you would also sclerose those varicosities. 3 systematic reviews have looked at the data of embolization for chronic pelvic pain in women. One is from Dr. Daniel's group, which was published in 2 different journals. The one that I'm going to spend the most time talking about is the one that's in the Journal of Vascular and Interventional Radiology. in the lower left corner. There was also a publication in the Journal of Vascular Surgery, Venous and Lymphatic Disorders from a group in Finland, and finally a US group publishing in the Seminars of Interventional Radiology, looking at Dr. Daniel's work, but all the systematic reviews found the same papers and came to the same or similar conclusions. There were 21 case series and one randomized control trial that they could find in the literature looking at embolization. And consistently, they found substantial pain relief using the visual analog scale, essentially 75% if you combine all the studies. They also noted that the pain relief was durable, at least to 36 months, and that there were low reintervention rates and low complication rates for this procedure. However, they also commented that the quality of the evidence in these studies was quite low. 21 of 22 were case studies, and one was a randomized controlled trial that they identified several significant flaws in. They also identified significant heterogeneity within all these studies that regards diagnostic criteria used to define the patient population, the treatments used in each of the technique procedures, including what veins were examined by venography and what veins were embolized and what embolization techniques were used. And the tools used to assess outcomes were quite heterogeneous. And in fact, the visual analog scale, probably doesn't fully capture the impact on patients from this disease, as we'll talk about later. And so in summary, they graded the evidence as very low and even as not so much related to the systematic reviews, but in terms of my impression, the evidence is even less good for embolization of pelvic origin, lower extremity or vulvar varicose veins, so embolization of the pelvic varicosities and the ovarian or internal iliac veins, and treatment of renal and iliac vein obstruction. There is some anecdotal data to support this, and there's probably rationale to actually look into this further, but the current evidence is quite poor. We have some big knowledge gaps at this time as well. We realize that the optimal treatment is not clear in either reflux or obstruction, but also the priority of what's more important, reflux as demonstrated on the left or obstruction as demonstrated on the right. So which one would you treat first? What would be the optimal technique for embolization? What would be the optimal indication for identifying treatment of the stenosis that would demonstrate clinical outcome improvement in patients, not so much the imaging criteria as the endpoint, but rather the patient response to embolization as the outcome. And what's the best way to treat left renal vein stenosis? Is that surgical or is that endovenous? So here's an IVUS image of a left common iliac vein. And if you calculate this out, this is about a 50% area reduction, but that seems kind of silly to think that that's going to cause significant pelvic venous hypertension. So I'm not a big fan of 50% area reduction as a criteria for treatment. I'm a little cynical, and I'd be cautious to encourage you to be so aggressive treating lesions like this. In distinction, this is a patient with a much more significant left common iliac vein lesion, and this one is something worth considering treatment if the patient's symptoms are appropriate and if the venography looks something like this, where you have a severe compression of the left common iliac vein and significant pelvic venous hypertension manifested by left to right varicosities that are collateral flow. And here's a diagram of that anatomy. So renal vein compression leading to pelvic venous disease, obviously we talked about this too. I'm also a little cynical about when to treat this. I'm not so sure we need to be as aggressive as some investigators are suggesting. Here's a nice venogram demonstrating the physiology. Note how rapid the flow is from the left renal vein to the right renal vein through the perivenous plexus. That's what's typical of left renal vein obstruction. If you have simple left gonadal vein reflux, the flow isn't so quick. You see the flow go down the left ovarian vein and it loiters in the peripelvic varicosities. Here, if you look at the venogram, you can actually see the left renal vein is compressed and all the flow is going rapidly down into the pelvis and rapidly up the right ovarian vein as an outflow. What to do to treat the vein, whether it's a left renal vein transposition as demonstrated on the left image, or a stent of the left renal vein on the right image, or whether the left kidney should be auto-transplanted from the left flank to the right groin, is still not defined. And different centers are doing different things without any evidence at this point. In terms of, again, now dealing with the other form of that we typically see, which are lower extremity pelvic origin varicose veins or vulvar varicose veins, my recommendation in these patients is, for the most part, don't image the pelvis and proceed to treating the varicose veins that probably were the reason the patient came, either the leg varicose veins or less commonly the vulvar varicose veins. Asymptomatic vulvar varicose veins, by the way, do not need to be treated in patients unless there's another indication to do so. In general, you can follow the response of this approach clinically, and then if patients continue to have symptoms, or if their symptoms recur, then you could proceed to treat the pelvic venous source, but that seems to be quite rare. Only 7% of patients who present with lower extremity pelvic origin varicose veins report pelvic symptoms, as in the paper cited here by Dr. Gibson. Most of the time, the patients are just bothered by the leg veins, or less often the vulvar varicose veins. So just treat those first, and reserve treatment of the pelvic varicose veins for failures or persistent symptoms. These are the two escape points in this patient: external pudendal on the medial arrow and recanalized umbilical vein varicosity. So injecting these on the upper thigh as high as you can is with a sufficient volume to both sclerose the varicose veins themselves and potentially even up into the pelvis is what's recommended. When the veins are smaller, you can do this by visual sclerotherapy with an empiric volume of either a liquid or a foamed sclerosant. But if the veins are very large, there is some anecdotal evidence that injecting these with combination of X-ray dye and sclerosant under fluoroscopy can lead to great closure of these kind of veins. But I don't have to resort to that very often. In patients with pelvic origin varicose veins and no chronic pelvic pain symptoms, we can do extremely well getting rid of the varicose veins. Here, visual sclerotherapy without the need for fluoroscopy, a picture on the left and a picture a year later on the right with success. Here's an X-ray guided image that's being collected during an embolization using sclerosis. So in general, pelvic evaluation and treatment first is the exception to the rule. We don't need to do it very often, but the situations where I would suggest that are recurrent patients. In other words, patients where you treat the varicose veins that are like the ones on the image on the right and they come back and you don't have a good explanation, or giant ones like this where there's probably another source. And in this particular case, there was an obstructive source that was leading to it. And so making sure you appropriately stratify patients will lead to the success. To summarize, there was a panel that I was fortunate enough to lead in October of 2017 that looked at the research opportunities in pelvic venous disorders. And ultimately what we concluded is we need better evidence, but we need better tools before we embark on randomized controlled trials. We need tools to ensure homogeneous populations, to establish disease criteria, to develop a SEEP-like tool so we can categorize patients well, and to develop patient-meaningful outcome tools so that we can identify the actual burden to the patients who are being affected by this disease and be able to attempt to measure that change over time. Those proceedings were published or will be published in the Journal of Vascular and Interventional Radiology later this year. There's also a guidelines committee being developed by the American Vein and Lymphatic Society that will try to develop a number of guidelines that will be multi-societal in terms of how to manage these patients. To summarize, there's several different clinical presentations of this entity, but this entity is best described by the term pelvic venous disorders rather than pelvic congestion. Treatment is tailored to the specific physiology of each patient. In patients with lower extremity varicosities or vulvar varicosities of pelvic origin without pelvic pain, just treat the varicosities that bother the patient, and that's almost always enough. But in women with chronic pelvic pain, you'll have to treat the physiology that's most important in each case, reflux and obstruction, but there are a lot of unanswered questions, and we hope to be able to solve those quickly. And again, I thank VWIN for the opportunity to speak to you today, and I hope you find this information useful in your practices.